Hello there, Andrew Colsky with Therapy BTS, Therapy Behind the Scenes. And today we are going to be talking about a topic related to OCD, one of my personal favorites. We're talking with Kari Gregory, and she works in a relatively newer area of OCD treatment called I-CBT. And I'm not going to spoil it for you. Kari, welcome, and could you introduce yourself to the audience?
Sure. Thank you. Thank you for having me. So I'm Kari Gregory. I'm a licensed professional counselor in Kansas City. I'm licensed for both Missouri and Kansas. I'm right on the state line there. So I do telehealth in both states, but mostly in person. And I've been treating OCD as a specialty since 2016. So, yeah.
Wonderful, wonderful. Now, is that like your primary practice, or is that part of your practice?
Well, I would say it's part of my practice, but maybe about 65 to 70% of my current clients have an OCD diagnosis.
Wow, wow. Okay. So, what is it that got you interested in treating OCD in the first place?
Yeah, I am. So I'm a second career professional. I did sales and marketing for about 20 years before I went back and got my master's degree in counseling psychology. And then after I did that, I worked in community mental health for a few years with a foster care program, and that was just a lot of trauma work, and that was a lot for me. So I knew I wanted to do private practice at some point, and anxiety because doctor heal thyself, right? Like I've always struggled with anxiety for as long as I can remember. And so I did a training specific for CBT for anxiety disorders for my certification in CBT. And that's where I was introduced to ERP. And when I advertised as an anxiety specialist, I happened to get one of my very first individual, like private practice clients presented with very common, thank goodness, because I now know that it can present in a lot of different ways.
Mhm.
But she was pretty textbook in her presentation of OCD. And so I loved working with her, did several consultations with the training person that I went through, and just sort of decided at that point that I wanted to add that as my specialty.
Fantastic. But I want to stop you for a second
Yeah.
and have you define for the audience. You use the terms CBT, you use the
Mhm.
terms ERP, and you use the
Uh-huh.
terms OCD. Can you define
Yeah.
those three for us?
As best I can. Okay, so OCD, obsessive compulsive disorder, which is characterized by having unwanted intrusive thoughts that cause a lot of distress. And in order to mitigate those thoughts, the person is doing compulsions. So the compulsive behaviors are to feel better about the bad thinking, but ultimately reinforces and becomes a loop that clients get stuck in.
Great.
Cognitive behavioral therapy, CBT. Um, so this is CBT 101. Our thoughts impact our behaviors, impact our feelings, impact our behaviors, impact our thoughts. And all of those are working together to either help us get out of a spiral or work our way into a spiral.
Great.
Um, and what was the other one? Oh,
ERP.
ERP. So ERP is an offshoot of CBT. We think of it as little cognitive, big behavior, right? So little c, big B, where we focus a lot on the behavioral aspect. And doing an exposure means I'm going to expose myself to something I might typically avoid or be afraid of. So I'm going to actively do that behaviorally, and then practice not reacting to that, allowing for whatever to happen. And then that retrains the brain to say, I don't have to do a compulsion or behavior in order to mitigate this emotion that I'm feeling.
Fantastic. Yeah, I just didn't want people to be wondering what do
Mhm.
all those letters mean? So thank you. You did a beautiful job with that.
Yeah.
So okay, so you had this client and you were first dealing with your first OCD case. So
Yeah.
tell us what happened from there.
So it was actually a pretty challenging case, but like I said, she did present um pretty typically. And so, what I mean by that, many people think OCD is cleaning, ordering, right, or being particular about something. Um, Mostly people think about the whole germ phobia aspect
Hmm.
of OCD, and it really is so much bigger and so much greater than that. But that was what she presented with. And so we also had to do quite a bit of cognitive work to even get her ready to do exposure work. So we spent a lot because it had taken over a lot of her life. She was spending, hours upon hours in a day just cleaning and cleaning and cleaning. And so she was feeling pretty depressed too, which is comorbidity. Often alongside of OCD is depression because of the hopelessness that clients feel when they cannot believe that they can get out of these compulsive behaviors. So we did a lot of cognitive work, value work, helping her to feel more confident in herself. And then we moved into doing exposures. And, the way that I was taught is we create a hierarchy. So at the bottom of the hierarchy are things that aren't as difficult to do. And then at the top of the hierarchy is kind of like, oh, hell no. Right. And so we slowly work our way up to, okay, can you walk back in a room after vacuuming it instead of having to walk backwards through your house? Can you let your dog sit on your lap, right? Like all the way up until the person can conquer all of those fears.
Hmm. And,
So that's what we did.
and how did she do with that treatment?
She was a champ. She was so good. And it was very slow going. Um, Probably for several reasons. The severity, I think now I would even pause a little bit at taking on a case of that severity without some maybe higher level of care, but not knowing what I didn't know. Um, we just went very, very slow. I saw her for about a year, weekly for about a year,
Hmm.
doing that intensive exposure work. And she would come back, after some sessions, after we really got it under the belt and she understood, like, oh, if I do this, I actually can handle it. She would come back sometimes going, okay, well, the dog ran around the backyard and I had no choice but to pick him up and bring him in the house. And so that was my exposure this week. And she would have these just regular life situations that she was handling and feeling more and more proud of herself. So she was able to do more and more and more. So yeah, it was really phenomenal to see her growth.
Yeah, that's one of the benefits of treating OCD that I like about it is because you see the results and they're pretty amazing. The person starts in one place and they end at a totally different place, and it's very,
Mhm.
it makes you as the therapist feel good because you know that you're having a success with that particular patient.
Yeah, yeah,
So,
yeah.
so when you treat patients, do you do in office? Do you do telehealth? What do you do?
So I do both at this point. Before COVID, I didn't do any telehealth. Everything was in office, and then I would go to. I've been in homes before and gone out into the public to do exposure work. Um, but mainly in office. And then after COVID, of course, people got used to being home. So I do a hybrid now. Some people I see online. And, working with exposure and response prevention via telehealth is actually phenomenal because you can go, okay, well, let's go in that bathroom. And what would you typically not touch? And they'll just bring their computer or their phone in there and we're walking through it real time,
Mhm.
and you don't have to be quite as creative of trying to recreate that in an office setting. So it can be really, really helpful either way, I think.
Yeah, I've said the very same thing when asked that question. I personally do mostly telehealth, and I really like it for exactly that reason. So many clients have issues that are related to something around their house or something, and to
Mhm.
be able to have them actually in the situation while we're doing the work is
Yeah.
so much better than having them come to my office where they can't. All they can do is sort of imagine it. So
Yeah.
I'm a big proponent of telehealth, and also for the other reason that you have a lot of people around the country who are in communities that don't have access to a therapist who is trained in OCD. And
Mhm.
so telehealth, they get access.
Yeah, absolutely. I do an OCD support group, and I'm only licensed in Kansas and Missouri. Hopefully the compact will um, help, spread that out a little bit. But I have clients that are all over both states because there are just not enough resources. I don't know that there's any other support groups specific to OCD, um, that you don't have to be a client of that practitioner. So this allows me to offer some support to people broader than my area. So it's
Right.
good.
Yeah, no, that's a great thing because there are not enough therapists trained in OCD. And, one of the challenges is that a lot of people who have OCD and they see a therapist, sometimes or oftentimes it's missed. The therapist,
Mhm.
unfortunately, we don't make that a
Yeah.
part of the training. So people come out of
Yeah.
school and they've never heard of much about OCD at all, and then a client comes in and they've got classic textbook OCD, but it's missed. And
Mhm.
so that's one of the purposes of this podcast, is to help educate people about what this thing is. What are you going to see when you see a client with OCD, and what do you do about it? So
Mhm. Mhm.
hopefully the word continues to get out and more people get help. So so
Yeah.
you start off, you work with this first client, you do exposure
Mhm.
therapy, you have the success that
Mhm.
you have. Where do you go next? How does your practice grow from there?
Yeah, so I just start, again, I'm just advertising myself as an anxiety specialist, and most people don't realize they have OCD. So they come in, I'm anxious, and then you do a few assessments, and you're like, okay, I think we might be talking more OCD than anxiety. And so it was just building up on my own skills, and then working with more and more clients. And then I did my formal ERP training through the BTTI, the IOCDF Foundation. And after that, I had an anxiety IOP group here in town that was like, would you come do just a quick talk on OCD and ERP for our IOP therapists? And I did. And after that talk, and a lot of other therapists came to that, just, for a free CEU, right?
Mhm.
And that's really where I blew up. I had a lot of therapists go, "Oh, I think I have a client with OCD. I need you to work with this person." So it was just really word of mouth after that. So
Great.
it's been great. I stay very busy, as you can imagine.
Yeah, fantastic. No, that's fantastic. So you start getting busier, you start getting more clients, and then how
Mhm.
does that get you into I-CBT? Tell us about that.
Yeah. Yeah, yeah. So I like to stay pretty connected with the greater OCD therapist community. So there's a Facebook page. There's, the ADAA and the IOCDF and all of these things. Well, I was doing a consultation group with Mike Hetty, who's out of Maryland. And there was like, I don't know, 5 or 6 of us in this consultation group. And he starts talking about I-CBT. And I'm like, Mike, I don't know what you're talking about. And so he starts introducing it more and more to the group. And then I bought the book, and I'll tell you what, I tried to read the book a couple times, and I'm just like, I can't. It's very deep. It's very philosophy sort of heavy, because the creators are PhDs in philosophy. And so it took a lot for me to go, okay, I'm really going to dig into it and try and figure it out. So that book probably sat on my shelf for about 6 months before I said, let's figure it out. Um, and then once I started learning it, and got connected with some other therapists who were also trying to really learn it, it just really started to click. It's very different than ERP.
Mhm.
and how I was trained to treat OCD. So when at first glance, it looks like, oh, you're refuting content. And that's not at all what it is. So it's really hard to get your head around, wait, what are we doing here? We're using logic. So yeah, it's a bit confusing,
Right.
which is why it took me a little bit. It's kind of like, have you ever seen that guy try to learn to ride the bicycle with the handlebars turned the other way? You'll have to look up this
Oh,
video on YouTube. It's like trying to learn to ride a bike backwards,
wow.
basically.
Interesting. Well, I want to, define for people that, I-CBT is inference-based CBT,
Mhm.
right? Cognitive behavioral
Yeah.
therapy. And
Yeah.
so tell us, in basic English, if you can, what
It's hard.
what is it like? How is it different from exposure therapy?
I will say there's a few really key things that are very, very different from exposure therapy. So, exposure therapy, like I said, it's the big B, it's all behavioral. Not all, but it's a lot of behavioral, right?
Mhm.
And the idea here is we're going to increase our tolerance for uncertainty, right? We talk a lot about that. And so when we're doing exposures, we want to increase the distress that the person is having so they can learn differently. So it's really focused on what's considered the back end of the OCD cycle, right? The very typical cycle that everybody sees is, you know, obsession, distress, compulsion, relief, which I think we all know is a little too simplistic. Most people
Yeah.
don't actually feel relief from their compulsions, but it's really focused on that back end of the compulsion relief part.
Hmm.
Um, I-CBT, inference-based ICB or cognitive behavioral therapy. So, what is an inference? A lot of us don't even really know what that word means. So, thinking back to like high school English and grammar class, we can infer something. So that's the way that we can imply something. So if I'm saying something to you, I can imply what my meaning is. You infer what my meaning is. You use your own logic, right, to understand what I'm trying to say. So this is similar to that, right? It's using logic and past experiences to come to a conclusion about something is to infer.
Okay.
So the theory here is that if you go all the way upstream to the trigger, we're making invalid inferences that are making that trigger a trigger because triggers are benign in and of themselves, but with a story, that's where they become problematic.
Okay.
So we're unraveling that story so the trigger doesn't trigger you anymore.
So if we took a very stereotypical OCD case of like contamination, like take
Mhm,
the first client that you were talking about, and let's
mhm,
say client comes into your office and they say, I'm having a lot of trouble. I'm really scared to touch doorknobs. I'm really scared to touch things in public because I'm afraid I'm going to get contaminated. And that fear leads me to be concerned that I'm going to get sick, maybe even die. And so I find
mhm,
myself washing my hands a lot and I can't seem to get out of this cycle. If that person came to you with that, how
mhm,
would exposure therapy look first? And then how
mhm,
would I-CBT look as comparison?
mhm. Yeah, so exposure therapy, very high level,
Mhm.
obviously,
Mhm.
right? Exposure therapy is going to go, okay, well, we don't know whether or not you're going to get sick. Maybe, maybe not. But we're going to touch it anyway, and we're going to learn that we can handle it. We can handle if we get sick, and we can handle the distress that it causes us if we get sick, or just to touch it, right? So we're going to go and we're going to start touching every dirty thing, and we're going to touch our face, and we're going to touch our bodies, and we're going to contaminate the heck out of ourselves until we can tolerate doing that enough to live our lives. And hopefully, what you're getting to with that is that brain training and learning that, oh, this actually isn't as unsafe as I thought it was going to be.
Okay.
I'm not sure if I can break this down that easily for I-CBT, but we're going to slow down the process and we're going to get person all the way back to the trigger. And let me take a pause here for a second. I-CBT has a 5-step sequence to OCD that I have just taken to given everybody, whether or not they decide to do ERP or I-CBT. This is how I explain OCD, because I just feel like it's a little clearer of a picture.
Okay.
So trigger, right? So I see a doorknob, and then obsessional doubt. And it does get into the difference between, well, what's reasonable doubt and obsessional doubt? That's a little deeper into the conversation, but it's like trigger, then obsessional doubt. What if I get contaminated by this doorknob? Or what if this doorknob is contaminated? Maybe that's what it is, right? Then consequence. And this is typically where people spend the most time worrying, right? It's like an if-then statement. So if this doorknob is contaminated, then I will get sick. And if I get sick, I will get my family sick. And if I get my family sick, I will be responsible for getting them sick. And I won't be able to forgive myself, which leads to the anxiety, dread, distress, or whatever, right? So that's the 4th step. So that's where I wouldn't be able to live with myself if I got my kids sick. That would mean I'm as a bad mom or whatever, right? And then 5, compulsion. So now I'm doing something in my real life, right, to mitigate this possibility of my obsessional doubt. So we start slowing this process down because we want to focus, like I said, at the front end of the sequence for I-CBT. So the trigger, I see a doorknob, and then I go directly into my obsessional reasoning. So we have to break that down for people. Okay, well, why do you believe that doorknobs are dirty? A lot of times there's really compelling evidence, logic, story, right? About, well, I've read about that. And, germs are everywhere. Every commercial tells you need to be spraying everything down with Lysol, right? Like, there's very compelling reason. But it's not keeping you in the reality of the here and now. I can look with my eyes and see that the doorknob is not dirty. I'm creating a narrative that's making me afraid. And we're going to ultimately work on staying in the present moment, building trust in your senses, because as you probably have seen too in your practice, OCD clients do not trust themselves. They don't trust their senses, that what they see, what they can feel. They don't trust their even sense of self, right? And so the goal here is we're building that up. You can trust your perception, and perception beats out imagination. And I have always talked about anxiety in this way, which is probably why another reason why this resonated with me so much. But for as long as I can remember, I've always sort of told people, anxiety is all about our imagination. Because what is it at its core? It's our ability to perceive future threats. Okay, well, can you see the future? No. Do you know the future? No. Nope. So where does that come from? Our ability to imagine.
Right.
And then there's no bounds in there. These things can create anything, right? And there's always a, but did you think? And so that's not the way we live our lives outside of OCD. So there's nothing wrong with the reasoning process of people with OCD. It's just once they triggered their particular vulnerability, now they're in OCD reasoning. And we just help them get back to reasoning the way they do outside of OCD.
Great.
Yeah.
So once you started to incorporate I-CBT into your practice, is that something that you do, only, or do you also use ERP, or how do you work with both of those?
Yeah, it's really difficult to combine the two because the theories are so different, right? So it's not something that you would be like, let's dabble a little bit here and dabble a little bit there. I-CBT is manualized. It's a manualized approach of 12 modules. But like I said, it has changed sort of the way that I approach starting off with people. And I give them the choice. Most people know of ERP. If they're coming to see me, they know most people have already been diagnosed with OCD and they're seeking out an OCD specialist, or they're being sent by a previous therapist or something. So, as most of the clients have already researched it pretty extensively and know that ERP is quote unquote gold standard, right? So
Mhm.
I give them a choice. I explain the two models, and then they choose. And so some people are like, yeah, I don't want to do exposures. Great, we'll do this approach. And some people are like, no, this is the gold standard. This is what I want to do. Right. But, I think it's super important that we have these multiple modalities, because ERP, as effective as it is 65% effective, I think is the latest number. So that means 35% of people aren't getting better. And that's not great, right? And so we need to have another option that's as effective, that's evidence based. That and there are other options too, right? There's ACT is very effective. Um, there's metacognitive approaches that are pretty effective. There's mindfulness based for OCD. So ERP gets all the press and it is very effective. And I still use it, and I use it a lot for other anxiety disorders too. But, there are other options.
So
Did that answer the question?
it,
I think
it,
I
it
went off on a
did.
tangent.
No. I appreciate the information. And I was going to ask the follow-up question, which was, so in your personal experience, um, the patients that you use I-CBT versus the patients that opt for exposure, um, are you seeing roughly the same success rate? Are you seeing one better than the other? Like what are you actually seeing in practice?
Mhm. I would say it's roughly the same. Yeah,
Okay.
it's roughly the same. And I have had instances where I've started with one and we weren't making traction, and gone to the other, both ways, with ERP and then moving to I-CBT, and I-CBT and then moving to ERP. I had one client who came back from an IOP, and in their step down, I just introduced I-CBT. I was like, ERP, you've been doing that and you have made a lot of progress with that. But here's another approach that might, help get you a little farther.
Mhm.
And that person really appreciated the difference, because it helps. One thing that I think is really helpful that I think ERP kind of misses is clients want to know the why.
Mhm.
Why this thought? Why am I having that thought? Why? And when you break it down and help them see all of that logic that they've used to create the narrative, it makes more sense to them. And there's something that is called the vulnerable self theme in I-CBT that is a real aha moment for clients. It's like, oh, because this, it really explains, well, okay, I have this one thought that's harm OCD. I have this other thought that's germ OCD. I have this thought that's, whatever. Doesn't make a lot of sense. It's like I'm all over the place with my themes. But the vulnerable self, the person who you fear you could become if you're not on high alert all the time, is a common thread across all of those. And then it's like, oh, that's that story again. There's that story about me being irresponsible, but I'm not. And you move on.
Right, right. Yeah, it's pretty interesting. And I forget exactly when I-CBT came out. I know it's a while ago, and it took a while for it to kind of get traction, and now it's really picking up a lot of traction. And I give a lot of credit to the authors, who created, because it takes a lot of research, a lot of knowledge, a lot of understanding, and I think they did a wonderful job with it. And in my practice, I guess it's similar to what you're describing in people's reactions and responses to things. And it really does, in the understanding part of it. Like what I do with patients, one of the first things we'll do is a little psychoeducation portion, where I will explain, here's what OCD is, here's how it works, and we'll look at the process, and we'll look at the cycle that they get, stuck into, and all that. And, by the time we finish that, and before we start treatment in earnest, they've got a pretty good idea of why they're doing what they're doing and how we're going to work to get them out of that. And I think that really helps them. I had one person, and this is a very one-off, but I had one person who I did the psychoeducation portion and explained what was going on, came back for the next session. We were going to start actual treatment. And he said, I don't need treatment. Once you explained it to me and I understood it, I don't need treatment anymore. So, I mean, that's a very
I
one-off.
one client like that too, just one.
Really? So,
Yep.
things happen. I mean, and there are those clients who go through treatment and still have, troubles, and they need different approaches and things. So I want to make that clear to the audience. This is not a, magic and everything is fixed in
No.
one session. But there are people, and I even had another client just this last week who, once we started the actual treatment, one treatment session, and he came back and he's like, I don't need it anymore. I'm done. Again, a very unusual one-off
Yeah.
case, but it can happen. So,
Yeah.
wow. So,
No, I think the psychoeducation is so important. You can't just like jump right in on day one with, okay, let's start touching doorknobs, right? Like
right.
you really need some foundation.
Yeah. Yeah. And I think they did a great job with that, with the I-CBT, of really breaking down kind of what's going on here and how does this all work, and all that. So again, props to them. I think it's wonderful. So let me ask you this: when you are working with OCD patients, do you often or sometimes come across co-occurring disorders that they may have?
Oh,
And
yeah.
are there any that seem to stand out more than others?
Well, I would say, I mean, the most common that I see is likely depression. Again, because of the hopelessness that it can feel, like you just have no control over your thinking and over your behaviors. So that would be what I see the most.
Hmm.
Yeah. And then of course, there's other anxiety disorders that can co-occur along with OCD, and they are specifically and different, right? So, and panic disorder. Yeah.
Yep. Yep. Yeah, definitely. Some of them, like when you were describing the levels of distress, you certainly
Mhm.
have some, again, not a whole lot, but some who may have even panic attacks when they're in that
Mhm.
distress. It's
Mhm.
so overwhelming to them that
Mhm.
they get so spun up that they get panic
Mhm.
attacks. And I've had
Mhm.
several of those. And it's interesting to work with them and see, again, through the progress of treatment, that all that kind of goes down and it goes away and it's not so overwhelming anymore. And so, the message to those listening to this podcast who may have OCD is, there is definitely help out there that can be really effective for a lot of people. So don't shy away from seeing a therapist for help.
Right, right. And I find, well, not just me, right? The studies, interoceptive exposure work is so helpful to that.
Hmm.
So helping people to, do intentional exposure to your internal sensations. That's what interoceptive exposure means. And you do learn that, okay, when my heart is racing, that does not mean I am having a heart attack. I need additional information, because I like to tell my clients, it's like, well, our bodies have a finite amount of like sensations they have, so they have to reuse them a lot.
Right.
And panic feels just like excitement. So it's like all about how we're thinking about
Yeah. Yeah. No, it's again, I just personally love the field, and that's just me. It's something that resonates with the way that I think and the way that I like to work with clients. And it just, I don't know. I've just found an interest in it. So so tell us this. You practice, you said you're licensed in 2 states. So if somebody wanted to get in touch with you, how would they find you?
My website, which is karigregorylpc.com.
Spell that out in case they don't know how to spell
Yeah.
Carrie.
KARIGREGORY LPC, all one word,
.com.
.com. Mhm.
Got it. Okay. And the support group that you said that you run, so
Mhm.
anybody can join that, or do they need to be a patient?
They do not need to be a patient. It's an open support group. It runs from February to October. I've been doing this now. This will be year number 4. Um, you do need to live in Kansas or Missouri for now. It's $35 per session that you attend. You can drop in, drop out, however you like, and it is virtual.
It's virtual. Okay. And how would somebody join that?
Mhm. Yeah, you can go to my website and click on groups and send me an email. That simple.
Oh, fantastic. Okay,
Yeah.
great. And when you say it's virtual, do you use Zoom or what technology in case?
I use Google Meet because
Okay.
that's what I've got my BAA with.
Okay, great. Fantastic.
Yeah.
All right. So one other question for therapists who might be watching this broadcast
Mhm.
who
Mhm.
have not had training in any sort of OCD treatment or anything, what would you suggest to them? Meaning, would you suggest that it's a good field to go into? And if so,
Mhm.
what would be their first steps to start getting into it? What should they do?
Yeah, I think yes, it is a great field to get into. It is underserved. I think it still says about 3% of the population, but it feels like it's probably more because it does go undiagnosed so often.
Yeah.
Um, and I know even in my area in Kansas City, which we have a ton of therapists, there's a handful of us that focus on OCD. So yes, it's such a great field to get into. I would suggest probably starting with the IOCDF.
Mhm.
They have a wealth of information there. They have podcasts and you know seminars for therapists as well as for clients. The ADAA is another, it's one of my favorite professional organizations that focuses a lot on OCD. I got started on their OCD SIG, and they have a monthly meeting where you can just call in. It's free. You call in, you can get consultation, you can learn about new um, treatments and whatnot. And then definitely take a training. Um, what I'm finding, people who are learning I-CBT before ERP are people who tend to be more trauma focused in their work, um, not necessarily CBT therapists. Um, it seems like most CBT therapists, this is totally just my observation, start with the ERP,
Mhm.
in learning, and then move, or if they do or don't, right? But and you're not going to go wrong with either one. The foundations of both are fantastic. Um, but I would also suggest you learn as many of the modalities as possible, and just don't be afraid to just keep learning because it presents in so many different ways. Like, it still surprises me today how it can present and be sort of completely covert, and you're like, oh, that's been there a while and just now finding it. Yeah,
Yeah.
so
No, I agree with you. I think that the more training you can get and the more you expose yourself as a therapist to the different models, and it just broadens your understanding so that you become more agile and nimble. So when you're working with different patients, like you say, you may switch from one to the other or back and forth. And, there's a whole lot of different opinions out there about the different theories and all. And, all opinions are fine. Everybody comes up with their own determination. I tend to fall pretty much where you fall, which is I'm going to use the right tool for the right patient at the right time. I don't discriminate between tools. We want to help, at the end of the day, we want the patient to get better. So, I like all of them. I tend to, it all kind of mixes because it adds to your global understanding as a therapist. So it's always in your mind and you're thinking about what you're doing and how you're doing it. So, yeah, I think definitely training in ERP, training in I-CBT, both are, really important as you get started. I think they're both really helpful, and you'll make your own determination as to how you want to, go about
Yeah.
using it.
What resonates best, yeah. And ACT, I mean, I really love ACT. I've never been formally trained in it. I've just read a lot about it, and values work is so helpful.
Yeah, and when you say ACT, you're talking about acceptance and commitment
Acceptance
therapy.
and thank you.
Yep. And I agree. I agree. I sprinkle a little bit of that in too at times. And I find it to be helpful. So, there are, like you said, there's a lot of different ways that people may go about treating OCD. There's some of the, standards, the ERP, I-CBT, ACT. But it's the more you're trained, the more successful you can be. So,
Absolutely.
so with that, I want to thank you for your time. I
Yeah,
really
thank you for
enjoyed the
having me.
discussion. And
Mhm.
hopefully, those people that are watching have learned more about I-CBT. Maybe you've raised their curiosity and they can find out more about it and maybe get themselves trained. I think it's a wonderful way to go. So thank you for your time.
Thank you.